Dear students, today we're going to continue the functional overview of the upper limb with the nerves and vessels. So the brachial plexus, of course, is a very important nerve structure, and you can expect a question for sure in the exam about the brachial plexus or any of its branches. As I already showed it in the last lecture, in the first part of this functional overview, here with this smiley, I will show you the things that are very important for the exam, so things that you do have to know. The others are just for interest. So you have to know the definition of the plexus very well. So ventral rami of spinal nerves C5 to T1. And ventral rami of spinal nerves C5 to T1. This is the definition of the brachial plexus. And then, of course, all the branches, how the trunks are formed, superior, middle, inferior, how they are rearranged to form the cords. This is what you discussed in class and what you can look up in the books. So I'm not going to talk about the individual nerves and trunks and cords, but more about the lesions, the clinical importance. We have an upper and a lower plexus lesion, and you do have to be able to mention a few examples how you can get such a lesion. For example, the superior plexus lesion or upper plexus lesion can be during childbirth. Why? Because first of all, newborn babies have no such thick myelin sheath yet, so the myelination is not ready yet. So if it's pulled, or then it can be lesioned if the brachial plexus is pulled too strongly and the neck is pulled, it can be lesioned more easily. And this is a very important and very sad consequence of childbirth. Here you can immediately see that the newborn baby holds the arm in a different way. There is no flexion of the elbow because of the musculocutaneous nerve lesion, and so the flexors are all paralyzed. The arm is in inner rotation, adduction and pronation, and you can see how the child is lying in this two positions here. The poor baby has both arms lesioned. It's also called the waiter's tip hand because of the very typical position. Of course, anything else making compression or traumatic lesion in this area can lead to brachial plexus lesion. So in adults, very strong traumatic lesion or tension can cause a problem, or compression by lung cancer is relatively common, or operations, radiotherapy, compression by anything else, crutches or an extra rib can also cause brachial plexus lesion. What you very well have to know is the different nerves, radial nerve, ulnar nerve and median nerve palsy. This I also indicated with the sign, and I will also show you, and you will have to be able to show these lesions to the examiner. Radial nerve, ulnar nerve and median nerve lesion. So let's start with the radial nerve. And the radial nerve, we know, innervates all extensor muscles, so including the triceps, which extends the elbow joint, and all the forearm extensors, which make extension in the wrist joint. So if this does not happen because the nerve is injured, then the extensors can be paralyzed. Then we have so-called wrist drop or drop hand. Why? Because you are not able to make extension, so the flexors will dominate and you are not able to extend your wrist. If it happens way up before the branches are given to the triceps, then the elbow is in flexed position as well. So drop hand, radial nerve palsy. If we know how the radial nerve is running, we can identify some typical points where the radial nerve can be injured, actually anywhere along the humerus, because it loops around the humerus. In humerus fracture, where, for example, the radial nerve goes in the groove for the radial nerve, or around the elbow where it comes to the ventral side again, or inside the supinator canal where it goes through the supinator muscle. There it can be compressed as well. And here you can see a patient who had an elbow joint injury, and she was operated, and after the operation she had a drop hand. She couldn't move her hand for several months. Next nerve is the ulnar nerve palsy. Here we again have to revise what is innervated by the ulnar nerve. So of course, if we have an ulnar nerve lesion, then we are not able to move these muscles. So what is the consequence? It's called claw hand. And why is that position? Ulnar nerve innervates many muscles in the hand, all interosseous muscles, and 2-3 ulnar lumbricalis muscles, all the hypothenar muscles, and from the thenar muscles, the adductor pollicis and the deep head of the flexor pollicis brevis. What do the interosseous muscles do? Of course, they do abduction, adduction, and all of them together, plus the lumbricalis muscles, together to this position that I show in the picture as well. This position means flexion in the metacarpophalangeal joint and extension in the interphalangeal joint. So, if these muscles are paralyzed, then the opposite will happen. You will have extension in the metacarpophalangeal joint and flexion in the interphalangeal joints. And this is worse on the ulnar side because of the 2-3 the ulnar lumbricalis muscles. So it's a claw hand, but worse on the ulnar side. So this is the claw hand, and this is typical for the ulnar nerve. Of course, we have sensory loss as well. Where the ulnar nerve innervates the skin, there is sensory loss. If it is present for a long time, then the muscles undergo atrophy. So you can see here on this side that there is the muscles almost disappear, the dorsal interosseous muscles that fill this side. Here between the accessor tendons we would see the dorsal interosseous muscles. Those are atrophied, and so the hand looks like a skeleton. It's also called skeleton hand. Where can the ulnar nerve be damaged? Anywhere along its course. Of course, in elbow injuries, that's the easiest place, also because it runs very close to the bone in the groove for the ulnar nerve, and here it's quite superficial, so it's very easily damaged in the cubital area. Also, there can be tunnel syndrome, so anywhere where a nerve goes through a tunnel, there can be chronic compression. Like Guyon's canal, of course it affects only the superficial branch, but it can be compressed here too. The third main nerve lesion that you have to know is the median nerve palsy. It's called Benedict's hand. Why is that? You ask the patient to make a fist, and for this movement you need the flexor muscles, the forearm flexor muscles, and they are mostly innervated by the median nerve, except for the ulnar ones, so the flexor carpi ulnaris and the ulnar part of the flexor digitorum profundus. So when you ask the patient to do this, we'll be able to do it only on the ulnar side. So it's like I swear that Benedict's hand of benediction. And of course we will have numbness, sensory loss in 7 halves of the finger, of the hand, and chronic, if it's present for a long time, then the thenar muscles are also undergo atrophy. So here you can see atrophied, disappearing thinner cushion. And if you list which muscles are innervated by the median nerve among the thinner muscles, then you understand that the patient is not able to do abduction and opposition. So the abductor pollicis brevis is lost, but the abductor pollicis longus is not lost. So there is some abduction, but absolutely no opposition. So the opposition will be lost. So the doctor examining a patient will ask the patient to do this, to do opposition, because it's another sign of median nerve lesion. Where can the median nerve be damaged? Here it's a very superficial in the carpal region, but of course anywhere where it's running from the arm to the elbow region, and then it's very superficial here in the carpal region where it runs next to the palmaris longus tendon, and for example suicide attempts or falling on broken glass, pieces of glass, can cause injury of the median nerve. And as you know, the arteries are running on the side, so radial and ulnar arteries run on the side. So many times these types of injuries do not lead to death because the arteries are not cut through, but the median nerve is. And this is the carpal tunnel. This is a tunnel syndrome, which you do have to know. That's why I also indicated it like that. You know the carpal tunnel, canalis carpi. Anywhere, as I already mentioned, anywhere where a nerve goes through a tunnel, a canal, can be trapped, can be compressed. So there can be a tunnel syndrome anywhere where there is a tunnel. But the most common tunnel syndrome is the carpal tunnel syndrome. That's why you have to know this, and it's quite common as well. We know that the carpal tunnel includes the long flexor tendons and the median nerve, covered by the flexor retinaculum, which is a very, very strong ligamentous structure, and it allows no enlargement, no swelling of the area. So if there is any inflammation, there is no room for enlargement and the nerve will be compressed. This can be even with pregnancy, or if somebody works with repetitive movements in the with the hand. And this of course causes pain, numbness of the fingers, especially these three fingers. This is very uncomfortable because you can't feel what you are touching. So as I showed it here in the previous, we know that median nerve innervates 7 halves, so half of the fourth finger as well. But the really bad ones are these three that you don't feel what you are touching. And flexion of the wrist is also painful and weak. And in simple cases you can do compression to reduce the edema, but you can give injections as well to reduce the inflammation, and many times only the surgical treatment leads to permanent treatment, a permanent solution. Here you can see a case which we can see that this patient was operated. Here in the middle you can see this big cut, and you can also see that most probably the muscles were paralyzed for a long time because the thinner cushion disappeared. Now I will show some anatomical points which anesthesiologists use to anesthetize, to inject some nerves for local anesthesia. And these are all anatomical points that you learned now with regional anatomy. So, for example, you can block the whole brachial plexus or even certain chords. And for the orientation, this you can see a patient's axillary region. For orientation, they use the pulse of the axillary artery. Here you can see the different orientation points. You don't have to know this, I just wanted to draw your attention to the very important anatomical landmarks. Here you can see the cubital region block. here in the cubital region you can find all three big nerves, radial, medial and ulnar nerve. So you can basically reach all of them here. For the ulnar nerve it's very easy because we can feel these two bony parts, the medial epicondyle and the olecranon, and actually between the two is where the ulnar nerve can be even palpated. This is where we usually hit the ulnar nerve, so this is a position where we can reach it very easily. The medial nerve, for the medial nerve, the most important orientation is the biceps tendon, which we can always feel, and of course the medial epicondyle, it's kind of between the two. Next to the biceps tendon we find the brachial artery, and next to the artery we find the median nerve. And for the radial nerve becomes superficial, kind of superficial, and becomes again ventral. Here next to the biceps tendon on the lateral side, and this is the important landmark, and the lateral epicondyle, and it's between the two where the radial nerve becomes again ventrally positioned. If we go more distally, we find more and more points. I already talked about the median nerve, where it can be lesioned. The same point is where it can be reached next to the palmaris longus tendon. Here it can be reached for anesthesia as well, or the superficial branch of the radial nerve and the dorsal branch of the ulnar nerve can also be reached. This is again something important for the exam, the anesthesia of the fingers. And if you learned anatomy, if you learned the anatomy of the hand, you remember that the fingers are reached by nerves from both, and arteries as well, from both sides. So the common palmar digital nerves divide into two at the root between two fingers, not in the middle. So it means that one fingertip is reached by two neighboring nerves. So for example, if this situation requires surgical intervention, then you need to give injection to both sides, where the proper palmar digital nerves go out to the fingers. This is called the Oberst block. After the nerves, a few slides I will show about the vessels, so superficial veins, some arteries and some lymph vessels. About the veins, I only show this one anatomical slide. You learned the superficial veins. Usually we want you to describe the veins starting from the periphery, so you follow the blood, how it flows, the blood flow. So you begin here in the dorsal venous plexus of the hand, and then you go to the cephalic and basilic vein on the radial and ulnar sides. Then you reach the cubital area, where we have an N or M form of anastomosis between the two sides, and finally the cephalic and basilic veins open into the axillary and brachial veins, so they open into the deep veins. Of course, superficial veins are very important clinically, because this is where, especially in the cubital or in the hand region, this is where we take blood samples from. This is where we give intravenous injections or infusions, and of course we can have consequences. We can have inflammation, infection, bleedings, so this area is very important clinically. Let's see a few things about the arteries. Of course, you learn the branches, the different parts, different segments of the artery, and you learn the branches, the individual branches. So I'm not going to talk about these, just I draw the attention to some important anastomosis systems. Here you can see that in the hand and around all joints we have important anastomosis. This is to ensure that in each position of the joints we have enough blood supply, and you have to learn these anastomosing arteries, or the two arches in the hand. So if you hold something heavy, from the deep arch we still have good enough blood supply. And you can use the anatomical points also for compression of bleedings. For example, the ulnar and radial artery we already talked about. These are superficial. Here you can easily compress the arteries if there is a distal bleeding, or you can easily reach the artery in the brachial region. The brachial artery can be easily compressed against the humerus, so it's easier to compress an artery if you can compress it against the bone. We use the brachial artery also for blood pressure recording, as you all know, and the radial pulse we use most of the times for the pulse measurement. And the radial artery can be also used for angiography and catheter. And here, in this case, you can inject contrast agent to visualize the lumen of the artery, for example, in the heart. This used to be done through the femoral artery. Now we also use the radial artery many times. Here you can see an example. For dialysis, so in kidney insufficiency, they build an anastomosis between a vein and artery. So these are the blood vessels that we use for the machine filtration. And finally, from the fingertips, we take blood, capillary blood, for example, blood sugar measurements. The last topic is the lymph nodes and lymph vessels. There was a separate lecture about the axillary lymph nodes, so I don't want to waste more time, just to draw your attention once more how important these are, the axillary lymph nodes. If there is an enlargement, your first thought should be breast cancer, and to examine the patient whether she has breast cancer, because breast cancer is one of the most common cancer types, and it gives metastasis into the axillary lymph nodes. Many times they have to be removed because they already have cancer cells, and in this case the lymph flow of the upper limb can be compromised, and in severe extreme cases you can have so-called elephantiasis. It means that the upper limb will be as big as an elephant's extremity. And this won't be asked in the exam, but because it's quite common, I want you to have one slide about this thing. This is an accessory mammary gland along this line. So axillary, during embryonic development, there is the so-called milk line from the axilla to the inguinal region along this line. And most commonly we have two breasts. The others are not developing, like in many animals who have more than one breast. And as a malformation, it can happen that especially the one below and the one above, there are extra numerary breast. Most of the times it's just a spot, but many times it's real tissue, and this especially can cause problems during pregnancy and breastfeeding, and it can be mixed up with a tumor as well, so you just have to know that it exists. Thank you for your attention.